Recently, I had the opportunity to host and invite Dr. Rick Schwartz, endodontist in San Antonio, Texas, to come visit us at the school and give a presentation to our endo residents at Harvard, as well as we invited the Tufts endo residents to come and join us for his presentation. I had a chance to also sit down with Dr. Schwartz to talk, and I wanted to share with you this interview. Dr. Schwartz had been a restorative dentist for 19 years prior to his decision to go back to school and become an endodontist. Now, during this time, he had written textbooks and first authors on topics on operative dentistry and restorative dentistry. But he decided all of a sudden he wants to become an endodontist, and then in endodontics, he also went on to lead and wrote books on contemporary endodontics and best practices in endodontics, as well as advanced CBCT, over 100 different publications, and his contributions to the AE connection has been many. So I sat down and I had this conversation on restorative endodontics with Dr. Rick Schwartz. Dr. Schwartz, we know that the restoration of an endodontically treated tooth begins at the apex. But what is the significance of coronal restoration in endodontics, and what makes for the ideal restoration?
Well, so after you complete root canal treatment, you don't want to have it get contaminated. So that's one important thing with the coronal restoration. It seals it, prevents recontamination. And the other is you want to do something to strengthen the tooth, and that's the other role. Strengthen the tooth, tie everything together, prepare, in most cases, prepare for a crown. So it protects the work that you've already done, and it helps the longevity of in the future. There's so many things that we don't have any control over in endodontics, like the patient's physiology, their microbiology, how compliant they are. But one thing that we can control is how well the tooth is restored, at least the initial restorative. If you look at the literature, that's a very important part of longevity in teeth that have had root canal treatment.
Yeah, I mean, so the ADA recommends cuspal coverage for posterior teeth. Do you think, first of all, that still stands in the age of adhesive dentistry and additive dentistry? And if there are situations in which we can get away without a crown, what are those situations and what are your recommendations?
Okay, so many of the teeth that we do root canal treatment on already have crowns on them or have large restorations, and so it's not that much of an issue. But sometimes we have teeth that are largely intact, and if you can do the root canal treatment with minimal damage to the tooth, minimal removal of tooth structure, and then place a restoration, a bonded restoration, especially if there's enamel all the way around it. Many people say in that situation you don't need cuspal coverage. For the teeth that are structurally weakened, then generally, yes, you do.
Do you think the marginal ridges are a good factor in those cases when you want to make a decision if the mesial and the distal marginal ridges are intact?
Yeah.
Would a crown be absolutely necessary or not?
You know, again, it's kind of a judgment. It's usually up to the restorative doctor what they want to do.
Right.
But my recommendation, in a largely intact tooth, and especially if the marginal ridges are intact, just an intracoronal or a bonded intracoronal restoration.
A bonded intracoronal restoration. You feel the bond strength nowadays, given the fact that if you do proper bonding, the adhesive strength could potentially surpass the cohesive strength of dentin, right? Could that...
Well, in the short term,
in the short, right.
The key is enamel, though, because the bond to dentin gradually lessens over time, whereas the bond to enamel is quite stable. So especially if you have enamel all the way around, or if you have primarily enamel to bond to, those teeth are pretty strong. And if you look at the literature on crown preparations, they remove a lot of tooth structure. In an anterior tooth, they remove up to 80% of the coronal tooth structure, so they really weaken the tooth, and that's not counting making access to do root canal treatment.
Right.
So for anterior teeth especially, we often don't recommend a crown. For posterior teeth, it just depends on how intact they are. And also, again, these are just my recommendations. The restorative doctors are the ones that make the final decision. And sometimes some of them are just really believe that every endodontically treated, at least every posterior endodontically treated tooth should have cuspal coverage. And if the tooth's largely intact, I encourage them to do very conservative cuspal coverage. Stay away from the cervical area of the tooth, which is the area that leads to structural failure.
Right. You know, it's funny because we would think, like, you know, we're going based on what
people want to believe you. You would think that we would have some type of a science to consolidate and kind of say, this is the guidelines, this is what we got to do. Speaking of that, do you think modern materials such as stronger metals, such as zirconia and different kind of materials used for crowns that are now allowing thinner, crowns could help in reducing some of the excessive tooth removal?
Yeah, I think that's definitely true. Zirconia is kind of a mixed blessing.
Right.
It's very strong, and a lot of people use it like on second molars or posterior teeth for that reason, because they've had problems with other ceramic restorations failing. But the other side of it is it's very hard, and if the occlusion is not right, sometimes we'll have patients that come in that we've treated, and they're having ongoing problems that started sometimes once they got a zirconia crown.
Right.
And so we end up having to go in and reduce the occlusion and adjust it so that everything's hitting evenly, and then in many cases their symptoms go away.
Yeah, it used to be that we had the problem with porcelain not being able to, being so wear resistant compared to enamel, and now it's become zirconia. And it's true that in the long run, as their occlusion kind of wears off, you end up having these areas that are going to be higher, and that could cause their own occlusal problems.
Yeah, I like zirconia just because it doesn't break when you make an access through it. And also, since we restore when we do root canal treatment, we usually do the initial restorative on the tooth. It's very easy to match the color of the zirconia.
Is it?
So I like zirconia in that regard.
Yeah, but getting through a thick zirconia crown, there's nothing harder than that.
Yeah, it sparks and
you really have to control the heat on that because it does become prone to microcracks down the line. It breaks afterwards. Mm-hmm. Let me ask you this about, as an endodontist, supragingival margins or subgingival margins for these crowns? What do you prefer?
Well, I'm a believer in removing as little tooth structure as possible, so that's number one. And number two, supragingival margins, just the tissue tends to be healthier.
Yeah.
I work with a lot of really good restorative dentists, and most of them, if they can, do supragingival.
Yeah, especially in the posteriors. I can't tell you how often I see, these crowns that come in after endo's been done, and they've been put way below the margin in lower second molar or first molar. What is the purpose of that? I just,
The only reason would be if it was really a short crown.
Short crown.
Yeah.
That I can,
Otherwise, generally, and I tell this to patients sometimes, the less you can have done to your teeth, the less tooth structure you can have ground away, the better off you are in the long run.
Yeah, that for sure. I mean, speaking of that brings us to minimally invasive dentistry, MIE nowadays, or contracted access cavities and so on. There's obviously a lot of controversy on that with views on both sides. My saying I always say is that, all of us want to be minimally invasive. I don't think nobody's touting on being maximally invasive dentists, right? But the question here is, where do we draw the line?
Yeah, so I don't do the really tiny canal preparations and the really tiny accesses. For one thing, it just makes your job harder. And another is, the canals aren't as clean. The research is showing now that, the canals aren't as clean, which is not surprising. With some of the new irrigation devices, probably we can be smaller than we've been in the past. And so I've kind of settled in the middle. Some guys do really tiny preparations. I'm part of actually a research project that we're looking at those and comparing them to the bigger ones, looking at all different aspects with SEM. So the way it goes is we see a patient who needs to have a tooth extracted for some reason. If they consent, then we do whatever sort of preparation and irrigation we're going to do. We use gentle wave, we use hand irrigation, we use lasers, we do vital and necrotic cases, and then we extract them, put them in formalin, send them to Dr. Gary Carr, who's a endodontist on the West Coast who happens to have an SCM and a TEM and confocal microscope in his basement. And he images.
He's taking his microscopy game to the next level, right?
Yeah.
Not just operating microscope, but also an electron microscope.
To a much higher level. He's using artificial intelligence now to help interpret the... But anyway, one of the things that we've found is that the really tiny preparations, even with the adjunctive irrigating devices, the expensive irrigating devices, they just don't get as clean. They don't look as clean visually as the larger preparations do. And when I say larger, I'm not talking about huge preparations, just moderate size.
Right. And it does make sense, not only for delivery of higher volume of irrigants, for finding canals, but I think one thing that goes unsaid is, people look at these access preparations online, on Instagram, they see these tiny preparations. What we don't see is, how long that procedure took to achieve what it did. And if it is taking longer, considering the fact that we're not working on mannequins, we're working on patients that have limited, time span for opening before they start to get post-op TMD and other problems with their jaw joint. It is, I think it behooves us to make sure that we have the least complicated procedure that can expedite. That's what, I went to Northwestern, G.V. Black's saying that, the convenience form was always part of those form factors that he was in. And I think that's important.
I'll add to that, what we do already is hard enough.
Right.
I just feel like, why make it harder? It's funny, endodontics is, I think, the only place in society where people go around saying, look, mine's smaller than yours.
That's true. I think it's driven by pros people being so size conscious, because I've seen prosthodontists say, oh, my endodontics is great, makes these smaller access preparations. So yeah, I think ultimately it's about finding all the canals, cleaning and disinfecting. Those are the foundational things. It's not...
And do it in a way that just removes as little
as possible. Yeah. And I think the argument is over, where's that line?
Yeah.
And I think the problem is that we have a paucity of research that supports or refutes any of these claims. So therefore, in this vacuum of actually information, we end up having people, having their own opinions. It becomes opinion driven.
Right.
Speaking of removing bacteria and so on, I've been to lectures and presentations by material scientists, and I know you have background in material science, where they think microleakage is not a big factor or an important factor clinically. What are your views about that pre-operatively as well as after endo? What do you think the role of microleakage is in dentistry as a whole?
It's a good question. For many years, everybody in our specialty thought it was very important. And then Dr. Rakuchi came out with that article in around 2000 or so, where he showed a bunch of gutta percha that had been exposed sometimes for years, and yet there were no loss of bone periapically. So I guess the bottom line is we don't really know, but certainly less is better than more, less contamination is better than more.
Right.
And so our goal is going to be to isolate well and to restore it well, to keep it from getting contaminated.
I think this issue of microleakage, like many other things, is one of those multifactorial things in which in some people it matters, in others it may not. And so you can always pick and choose the case in which it didn't matter, and so it doesn't matter as a whole, and then the other way around. But I think as a whole, if we think of the concepts of endo being really a microbially driven problem, we all know that these composites or fillings that have open margins end up with decay in the long run and problems. So I think there is something to be said about that.
Yeah.
You've been a leader and educator, first in restorative dentistry and then on to endodontics, and now you've been practicing endo for nearly 25 or so years and still practicing about 4 days a week. What keeps you going? What keeps you motivated? You certainly don't need to practice, but why is it that you're still practicing so hard?
Well, I just enjoy it. I enjoy the interaction with the patients. Now I'm involved in a lot of online forums, and I enjoy that a lot. I just still enjoy the professional stimulation from it. At some point, probably, for one reason or another, I'll have to retire, but I'm not close to retirement now anyway. As long as it's enjoyable and as long as I'm physically able to do it, I'll just keep doing it.
Yeah.
Probably not 4 days a week, but...
Yeah, cut it down and enjoy it more. The bottom line is, I always say if the best situation is if your job's your hobby, right?
Yeah.
And you enjoy doing it. What is the retirement? The mistake that people make is they think retirement means you're just going to fold it and do nothing.
Yeah.
It's a question.
Well, that's true.
It's essentially retirement is just a financial retirement. You continue to do what you love to do, right? That's a whole different concept, I think. And that's
the other thing is I do a lot of lecturing too, and in order to have fresh material, you have to continue to practice and add new cases. You can't just
I agree.
keep doing the same stuff over and over again.
You got to be wet-handed. You can't just tell people what to do if you're not doing it yourself anymore. I agree 100%.
And things change and new technology comes along, and that's another thing that prolongs a lot of people's careers. I know back when the microscope first came along, there were a lot of a lot of endodontists that were just tired of it and ready to quit, and it just rejuvenated them.
Right. But to what extent, that's a very good point, and it opens up a whole question here as to what extent is so much of the technology is a solution to the fact that we might want to try something new, and to what extent is it an actual solution to these problems? You know what I mean?
You know, we don't really have research to guide us on these things when they come along, at least not for a long time. And so it's kind of a trial and error in your practice and see if you think it's making a difference. A lot of the new technology makes the doctors feel better, but not necessarily the patients feel better. I mean, endodontics, the way we've done it for many years, it has a very high success rate. If it's done well, you know, if you locate all the canals, you clean them relatively well by some method, and you restore the tooth well, you're going to have a lot of success. And also, I guess I'd add to that, if you choose structurally sound teeth to work on. But if you do all those things, you're going to have a lot of success with endodontics.
Yeah. Endo is very predictable, thank God, if you follow these basic principles. What do you tell your patients who need to have a primary endo in terms of the success rate that they should expect if there's no periapical lesion or if there is a large periapical lesion?
Yeah, so for the ones, you know, for the vital cases or the ones with no lesion, it doesn't come up that often actually, but if they ask, you know, is this going to last? And I tell them, well, nothing's 100%, but it's pretty close. It's pretty predictable, probably in the 90s somewhere. And for the ones with the big lesions, you know, I tell them they're not as predictable, and there's a chance that we'll also have to do surgery, but most of the time that's not the case.
Right. Well,
it's a funny thing in a specialty practice, and especially if you work with good doctors. I don't tend to get questions like that very often. I don't know if you do, because the referring doctors prepare the patients so well and they trust them, and a lot of that trust is transferred over to us. And so most of the patients I see, when they come in, they're going to do what I recommend. They've already decided when they walk in the door. So there's really not very much convincing or selling involved.
Right. And then the question really comes down to avoiding any misunderstandings afterwards. You know, one of my views is cases that have large lesions, you have to prepare the patient for the potential for follow-up visits surgically to make, if it's a large enough lesion, that it could be a cyst that have to be removed. And I feel like the fact that we call those large lesion cases, if endo doesn't work in endodontic failure, is probably allows further this misunderstanding. You know, that the patient would think that, you know, you have to have 100%, you know, the old Hope Schilder thing, you have 100% success minus X, X being the operator, as if we are gods. So I think it's just a good view, and I think we all agree that, you know, large lesion cases have a lower success rate in general.
And retreatments also, I think.
So
which is pretty much what the literature says too.
That's terrific. I just want to thank you for spending this time here before your presentation with me to share some of your views with our audience. You know, I have a lot of respect for you and all you do in the profession, so I'm really grateful. One last question I always ask people: what is your favorite paper in endodontics? And you can't quote Kakashi and Stanley. You got to come up with something.
Well, one of my favorite papers, just in general, was the one we were talking about last night.
Ionitis. John Ionitis. Yes.
That was one of my favorites.
That's the axe. That is what I call the hammer. So for those of John Ionitis was a professor of epidemiology here at the school at Harvard School of Public Health, where we are here, just, you know, a quick walk over the street. And he left Harvard, and at Harvard he published this paper back, I think it was in 2003, 4, something like that, about the fact that medical literature, not dental, I mean it was probably worse than dental, but medical literature is mired with inconsistencies and mistakes in terms of scientific design and so on. So about 80%, he said, the old 80-20 rule, 80% of the research is really not contributing to move the field forward, maybe flawed and inaccurate. He's now at Stanford, he moved on to Stanford.
Yeah. You know, we had him out in San Diego one time for one of the TDO meetings. He gave an all-day lecture. And one of the things he did was looked at some of the kind of classic endo studies. Like one he looked at in depth was Paula Eng's study around 2010 from Eastman in London. And he wasn't impressed.
That is true. I mean, we do use a lot of proxies for measuring success. Yeah. And we don't really, it's a multifactorial problem. We don't know much of it. And that actually has ended up being a problem with endodontists trying to reduce the success rate by having stricter and stricter criteria for success.
Yeah.
And now the implant people coming in and they just say, oh, you know what, as long as the implant's in the mouth, that's a successful case. And then going on to say that implants have a higher success rate than endo, which is not true if you consider perimplantitis. But anyway, thanks so much again. Look forward to your presentation, and thanks for spending time with me.
Okay, my pleasure.